I'm very honored to have with me today Dr. Damon Broyles. Damon is the VP of Clinical Innovation for Mercy Technology Services, part of Mercy's Office of Transformation. He's a board-certified family physician and a fellow in the American Academy of Family Physicians. He has subspecialty certification in clinical informatics. Prior to his current role, Damon served as the CMIO for St. Anthony's Medical Center. He serves as medical director for Mercy's Department of Precision Medicine. He volunteers as an entrepreneurial and health IT mentor at Sling Health, a national biotech and healthcare incubator with roots at Washington University. He participates on a community of health innovation leaders for the Global STL initiative and serves on the Missouri Biotechnology Board of Directors. He has previously served as president of the St. Louis Academy of Family Physicians, and he represents Mercy's perspective on an array of digital health and biotech board appointments. We are coming to you live today with an audience that is joining us virtually. So for those attending, please feel free to ask questions in the chat, and we'll get to those as we go through the podcast today. Damon, very happy to have you joining us. I know we've gotten to know each other a little bit over the past 6 months or so, but looking forward to diving deeper into your background today and some of the initiatives that you're working on at Mercy. So let's start at the beginning. Tell me a little bit about your upbringing and why you chose medicine as a career path.
Well, I think like quite a number of physicians, obviously an affinity for science was one of the things that drew me into medicine. I know that there's a whole number of mathematicians and physicists that would argue that those are the truest of the sciences, and I wouldn't argue with them. I really gravitated towards the biological sciences because it just, for me, was more intuitive. It seemed like there was sort of narratives that you could incorporate into how you understood the world around you and human physiology. So I just was always fascinated with those things. I also had kind of this overlay of my father working in the medical division of Hewlett-Packard. So I was exposed to medical technologies, and his experiences in hospitals and in physician offices, gave me some early perspective. Had, the gift of a number of really fantastic family medicine physicians who kind of solidified, in that time frame of high school and early college. Well, this is the type of medicine that I want to practice. The idea of generalism, being an expert in those things that are general knowledge, was really of interest to me, and it was intriguing. And the fact that you really can be well versed in all of these things. That variety of clinical practice was something that certainly in medical school was particularly intriguing. So it's kind of my backstory of why I ended up in the family medicine side of things as an early physician in a physician organization that was relatively new, and had an opportunity to be involved in the technology of here's an EHR, or this is the EHR initiative. We probably should get one. People, I got fingers pointed at me and said, hey, you're being voluntold to go out and figure this out. Which was a fantastic early learning experience. And so my ad hoc activities in doing that type of thing, learning by doing, really transitioned into, hey, can you teach these other physicians now that you have some experience in it? Realize that was enjoyable. There was a lot of internal gratification that I got from helping other colleagues with the understanding of how the technology can better serve them. And let's be honest, early on, the technologies were pretty rudimentary. And so helping them figure out how this wouldn't be such a burden to them was also part of that. Flash forward to today, I think we're getting to a place where we can start lifting those things off of docs and really transforming the idea of what it means to have an electronic record. But obviously the early work and those sorts of things was trying to make the best of the EHR capabilities, really pushing, what it could do, and, adapting and helping others adapt to the deficiencies and the things that were more cumbersome and awkward about it.
Now, you were CMIO at St. Anthony's for over 10 years. Is that correct?
I had ended up as a CMIO position. I probably had that named position for about 3 or 4 years. Prior to that was IT director for the hospital and the physician organization. And then kind of a role previous to that was the IT and IS medical director for a physician organization. So I graduated up through and matriculated up through increasing responsibility. I was lucky enough to have a fantastic mentor and a CIO that was also kind of moving into those increasing positions of responsibility and grabbed me by the coattails and kind of pulled me along. And so he was someone that had good experience in large health systems before. So he gave me some early lessons in the ecosystem of a hospital. And again, being a generalist, being in healthcare IT for a hospital, for a physician organization, it wasn't just confined to the EHR. It was the billing and coding systems. It was the EVS systems. It was dietary. So you got an array of opportunities to learn all the intricacies of how systems work together, which was pretty critical in being able to get a wide lens and develop further as a clinical informaticist.
Nice. So you've been in an executive role at Mercy for about 5 years now. How have you seen the organization evolve, maybe kind of before COVID, through COVID, and then after COVID? What have been some of those big, transitions as an organization?
Sure. So I wouldn't be any surprise to your viewers to learn that, prior to COVID, we probably thought we were going to be dragging clinicians and clinical staff into a more of a virtual world and utilizing the array of virtual tool sets and digital outreach. But, obviously with COVID and the crush of all of the urgent and emergent clinical realities, we had to spin things up very, very quickly. We had done some work in our video visit playbook prior to, and we actually were in the process of kind of slowly rolling that out, before COVID. And that was extremely helpful because we were able to say over the course of a weekend, here's what we have, here's how to do this, here's the things to look for, and be able to hand that over to our clinical leaders who are articulating that need. And then we built off of that. But the digital outreach side of things, we're because of the needs of patients that just far outstripped our system resources and our clinical resources, we were also innovating workflows and processes and digital outreach tools, working hand in hand with our patient experience folks, with our Office of Clinical Excellence, to put into place things that we had, COVID patient monitoring, daily check-ins. We had been doing work with a group called Care Signal for some time prior to that. And, some of their infrastructure was particularly helpful. We ended up working with our software engineering teams to build complementary strategies. It was, certainly something that everybody got comfortable with extremely quickly and really set the stage for the ability to pivot towards chronic disease management. And the other thing that was really important, and I think was well laid out, because it is not something that you transition quickly in a large health system, was a shift towards being really all in value-based purchasing and population health management. And that's something that really probably started 4 years before COVID, about the time that I started my tenureship with Mercy. And we were having conversations around how do we change the language of success from fee-for-service world to just starting to get people socialized around population health. I had the benefit of working in a physician organization early on that was very ahead of its time, I would say, in terms of risk-based contracting and value-based care. And so this was something that, as a family medicine doc, made incredible amounts of sense. And I'd seen firsthand how that really drives and aligns performance and quality and reduces utilization. But that was a relatively smallish physician organization. Doing something with an organization the size of Mercy, you have to really start planning the navigation, and that's a separate process than actually navigating. And so we had been doing that and adjusted our organization to have much more of an emphasis and an alignment of our population health teams and our primary care teams. And now we just went through another reorg where we actually have three performance divisions. One is population health and primary care, and they are inextricably linked. It's really hard to separate them at all. And I think rightfully so. And then we have a specialty performance division in operations/hospital. And the goal there is really to emphasize that you're not a diabetes patient in the hospital or a diabetes patient in the primary care clinic. You are a patient with diabetes, and you may happen to be in any one of those clinical care settings, including most of the time not in a brick and mortar facility. You're out here doing your thing, trying to stay healthy and maximize your disease processes. And so that's where we ended up. But that also was a change that occurred over a couple of years prior to and throughout the COVID pandemic. And that gave us a great understanding of how we could take all of these tools that were specifically deployed for COVID management and make sure that they were extensible and that they were easily redeployed for chronic disease management. And frankly, that was one of the charges of our senior leadership team as we were doing these things was, the COVID pandemic will end. It feels like it's never going to, but it will. And we need to be able to say all of these technologies and all of this build, we can't shelf it. It has to be easily able to be repurposed and to move quickly and agilely in a value-based environment.
Now, in a value-based environment, does Mercy as a health system have your own payer, or are those all relationships and contracts that you have with payers that are value-based?
Yeah, we do not have our own payer system. We're not an IDM, but we do have a very large cohort of patients who are coworkers, and so we're kind of there. I mean, that's an area that we do a lot of value-based pilot process development work for, because we control more of those levers. It's easier to message the why to that group of folks, and frankly, they're on the front lines. And so if we have a care innovation that we think is going to be super beneficial, then obviously it's a supremely important population to be taking good care of. The rest of it is our contracts with outside payers, and obviously the big value-based care programs with CMS. And we have fairly progressive relationships with those folks. And insurance companies are massive, and so there's different cohorts inside those payers that are probably more progressive and less progressive. But because of the execution in quality and the improvements on utilization and all of the successes that we've had, it really is accelerating the ability to develop payer and program innovations. And that's kind of our goal, is to really be setting the pace. And then everyone else has to keep up. And everyone is, to be proactive so that others are reactive. And I think that holds true for both other incumbent health systems as well as startups. In a diffusion of innovation scenario, if we're taking the best innovations from our startups that are trying to compete in this space or trying to break through, and we're adding those to what we know that we do well. And in Mercy, we have a singular, comprehensive Epic instance. We went through about 3 years ago a consolidation of 3 separate but identical Epic instances. Oh, wow. And now a huge initiative and program, but now there is zero difference from a record keeping and decision support and predictive analytics capability. If you're a patient in St. Louis metropolitan area or Ada or Blue Eye, Arkansas, or any of these places, you're going to have the same ability to have a comprehensive, cohesive chart. And so that's a massive advantage from a competition standpoint, regardless of who the competitor is. And if we can successfully adopt all of these upstart strategies and fold them in, then we've raised the bar for entry, right? We're kind of continually pushing what is required to enter in as a startup. Well, that's no longer here, it's up here.
Yeah. I mean, that is so huge that you guys have sort of taken your medicine in the past and are now reaping the benefits, because we know of many health systems that are in the midst of that right now. And unfortunately, their whole IT resourcing is in clinical informatics is tied up for the next 2 years, just trying to consolidate EHR instances and get the whole organization on a single instance. So that's amazing that you guys have already completed all that.
We benefited from some pretty visionary leadership that's foreseen and understood the how integral this was to be able to use as a force multiplier, frankly.
Yeah.
And we know from experience, even being on 3 identical instances, there was so much that we couldn't take advantage of, whether it be a native Epic feature that we had to kind of build for that patient that maybe crosses instances, and so it has can't just be deployed out of the box, or using and working with other outside innovation vendors to be able to really quickly deploy something that is best of breed and adds value to the ecosystem.
Mm-hmm. Well, I always like to ask this question, which I ask everybody, is what do you see as some of Mercy's top initiatives right now? And I don't know if you want to give top 3, top 5, but I always like to get an idea for kind of what you think those top initiatives are.
I can, the things that come to mind are the things that the themes that I get emailed about, on a near daily basis, different ways to approach the problems, but the themes are pretty similar. And so the one that, that comes to mind right away, vocational satisfaction in clinician wellness. And as we kind of mentioned before, we've really, over the course of a decade or more of EHR use and regulatory requirements and billing, we've inflicted a death by 1,000 cuts, and the solutions are 1,000 Band-Aids, and there's not a panacea. Although I think some of the generative technologies applied judiciously have a potential to be a step change and really a huge accelerant in the provider wellness and vocational satisfaction arena. We can talk more about that in a bit, but the blocking and tackling is really just going in and let's clear this decision point off. Like, we know that we don't need it. Why are we asking it? We know that we can glean that information further upstream. And the physician and nursing efficiency questions are just an everyday thing. Like, how do we continue to push that ball forward? And honestly, a lot of the innovation that we do is working with our clinical leaders and partners to do process innovation, to do workflow innovation, because technology is a part of it. But the build can enable new ways to think about how you deploy resources and new processes that don't tie up the cognitive processes of being a nurse or a provider. But the most efficient process is the one that you don't have to do. So if we can look in and do prediction, and be proactive with the help of our data science team, get upstream of the encounter, get upstream of the intervention, and do it for our clinicians, then that's a better, more efficient solution, because we're not even asking them to do a more efficient process. We're just saying, you don't need to do this at all. So those are the ones that are the most gratifying with regard to that type of wellness work and efficiency work. We mentioned data science, and that is another area of huge emphasis. We are incorporating all of our data sets, be they from our clinical operating systems like Epic, or from our CRMs, or from all of these other the RADONC technologies and those machines. Really trying to gather up all of that data and those data points, feed them up into an intelligent data layer that is able to look across all of those potential patterns, find relationships, find areas where we can get upstream of illness. It's really fitting. It kind of is a nice corollary to the Sisters of Mercy. One of the things that they would do is get out and walk amongst their community, which kind of frowned upon at the time, interestingly. But their whole goal and their founders was really clear on get upstream of illness. Find the things that are the precursors to why folks show up in such a sorry state of affairs and with end-stage illness, and fix those things that are there. which speaks to social determinants of health, right? It just echoes through the ministry of Mercy Healthcare. And that's, again, another area of emphasis where we are looking to not just identify, hey, this is a patient that has housing insecurity. This is someone who has food insecurity. Because if you just identify it and you don't give your clinicians an easy way to solve for it, you're bumming them out. You're making them sad. Well, I'm going to prescribe this other medicine, but I know it's really not going to be something that you're going to be compliant with because you have your pyramid of needs has all of these other more important, more pressing issues. And so being able to work with vendors on the outside that can source the solutions to those problems, we've done a lot of work in that space. And essentially, how can I prescribe something that is as easy to get at as an expensive diabetes medication? How can I get healthy food out there? How can I get resources to this patient so that they can much more easily fix the issues that are driving their housing insecurity, or a need for upskilling in the workforce, or all of those things that we know impact our patients' course of health and their disease trajectories. The other aspect, and we talked a bit about this, is the population health, all of the levers to be successful there. And those are, massively important. So we have a whole bunch of initiatives related to documentation and coding and making sure that we are effectively gathering up and communicating, what is the general illness level of our patient population, so we have enough resources to care for them. We're looking at access. We have this huge array, and it's really exciting over the last year and a half to see the different ways that our patients can access primary care at Mercy. It's very deliberate strategy on the part of our patient experience colleagues to be able to say, no matter what today brings for you as a patient, there's a primary care effective clinical option that meets your needs. And so that is something that part of that is being able to give our clinical offices the ability to act as their own virtual care center and have each of those options that is the most effective for the patient at that point in time be frictionless for the provider and for the clinical staff. Because it can't be a zero-sum game. It can't be something where we say to the patient, we're going to make this easier. And the trade-off is, oh gosh, for the clinical staff, that's going to be something that you have to adapt to and figure out how to work into your already busy schedule. Have to find those durable solutions that benefit both sides of that equation. And then those are sustainable. They stick because people want to keep using them, on both sides of that provider-patient equation. Patient experience in general for population health obviously is very important. And then the quality of care. And, Mercy historically has been, a very, very high achiever in quality metrics. And it's not just are you doing the right thing for the patient? Are you getting the interventions to the patient that they need? But it's also this other very complex layer of, are you communicating that you're doing those things? We just had a meeting this morning. We were, talking about with our experts in the quality data abstraction, and talking about how the communication of influenza vaccine status has changed from this year to what it was previously. And those are just massive machines of moving parts. All our providers and our clinic staff wants to take care of is just tell me who needs a flu shot. Make it easy for me to do that. And, don't make me go navigate all of this arcane language and documentation strategy to make sure I get credit for it, so to speak, right? They just care about, is this patient protected from flu? Are they not going to show up in the ER? And that's the way it should be. And so it's our job on the technology side to make that stuff invisible as best we can. And unfortunately, it gets, we're regularly challenged. We're regularly challenged by, payers who decide that, oh gosh, a CPT category 2 is the best way to communicate our quality, scores. I mean, it's just it's kind of mind boggling to some extent. And it's really frustrating when you think about all of the data that is contained inside of an EHR about what actually was done, that we don't even have to document. It's just in there generating user action logs. It's in there, how long did you spend looking at, the radiograph? What did you do after you did the medication reconciliation? Like all of that extra metadata is sitting in there. And we're continually, now we had this big change to our coding and documentation guidelines and the E&M codes and all of that a couple of years back. But we are still in a place where as you accelerate into value-based care, you're kind of swapping those documentation reductions for other documentation necessities to say, oh, you have to say that you did this. You have to say that you did this. And my hope is that we don't sort of replicate that original sin and the EHRs that we could have gotten ahead of. And we use more of the back end connectivity and the interfaces and those types of things to just do that on an invisible level. So we're not inflicting that sort of new beast of burden on our clinicians.
Yeah. One of your roles is to find innovative technologies and then, bring them into Mercy. What are maybe a few innovative solutions? And you can mention company names if you want to, if you're able to. You can just talk about use cases. But what are some innovative solutions you'd like to highlight?
Well, I think one of them that we're really in the midst of is working with a group that does scanning and more particularly, they do indexing automation. And this is one that's been sitting out there for a while. It was a challenge to generate the ROI documentation on it because the impact in our ambulatory clinics was really, we're going to take low value work away from this wide array of individuals, front desk folks, nurses. I mean, this work was done by just a potpourri of clinical staff members who arguably and easily all should be doing other higher level things, higher touch patient activities. And we get rid of it and allow them to do all of those other things. And that's a little bit of a challenge to make that argument because it's automation, but the point is automating so that folks can work at top of license. And I think, to some extent we were helped because there was an undeniable crisis in staffing levels. It is, readily apparent that we just don't have enough people in any clinic across the Mercy footprint or healthcare in general. And so that really drove kind of a rethink of how valuable is this? And so, this is something that we're very excited about. Other systems have some time ago done this type of work, but it fits with our emphasis on automation and the workforce challenges that we have throughout the health system.
What's your definition of indexing?
So, if you think about, okay, here's an outside document, it might be an echocardiogram, it might be something that a diabetic retinopathy exam, any of these types of clinical documents that are not integrated because they're coming in from non-Mercy entities. That's a long and drawn out and somewhat convoluted process to actually get that piece of paper or that digital fax into the right spot in the chart. And you've distributed that task across thousands of people. There's going to be variability in how it's done. There's going to be places that it gets put in the chart and it's not the right place. And again, it's work that shouldn't really be done by a human being because it's rote, it's tedious. They should be doing better things with their time. And so when we do this type of automation, we're really freeing people up to more effectively practice medicine as a clinic and as a care team.
I think we might have lost Brian. I came in.
I thought so.
As backup, just in case. We'll do audience questions as an intermission, but one that I had when you had started talking about AI a little bit, but do you think frontline clinicians are more optimistic or pessimistic about generative AI making their work more efficient?
Oh, I think massively more optimistic. I think that they're not in technology. There might be some nuance that they would readily admit. I'm not sure, how exactly it's going to interact and make this work better. But there's so much complex administrative tasks that are part and parcel of medicine that this is, I think, seen to almost a person as something that has a vast and enormous capacity for improvement of day-to-day life. So I think just in the very short period of time that the generative technologies have been available, most people have tried them out if they're at all tech curious, and it's very easy to get a visceral understanding of where this type of technology is going to be of incredible benefit as we sort of navigate the administrative tasks of medicine. And that's up to this point has been one of the crux problems of reducing administrative tasks in medicine is there's not very many pure admin tasks. If you're doing robotic process automation as an example, and you're looking at rev cycle, there's a whole lot of, hey, you got to move this sum over to this column in this different spreadsheet, or you got to move this, payer adjudication from here to here. And that's a fairly black and white automation and a fairly black and white mappable administrative task without a lot of sort of variability that would require a human in the loop or a attended process. There's not a whole lot of those true administrative tasks on the clinical front lines. There are administrative tasks, but they always are to a large degree, they require some level of clinical discernment. There may be other folks in the office who can apply clinical knowledge, but they're just not true admin tasks only. And I think that that's where this ability to kind of stack technologies, be it the generative plus true automation technologies plus data science strategies, adding those things together and stacking them and allowing them to be referential to one another is going to go after those mixed use problems in the admin space of healthcare.
Yeah, thank you, Brian. Just so you know, I took us in an AI direction while your internet went down. So I asked an audience question, but I'm glad you're back and let the doctors handle it from here.
Awesome. Thank you, Spencer. Yes, apologize. One of the joys of being on the road in a hotel is inconsistent Wi-Fi. Well, Damon, just a few more questions here. I mean, this has been awesome. One of the projects, that you guys did at Mercy was something called wherefore.care.
Yeah, that was actually a startup that I was involved in. So that wasn't a Mercy initiative, but that was something that came out of that Sling Health collaborative and that group that you had mentioned earlier. So that was some time ago. It was a great foray into. It is more chatbot. It had some natural language processing, but it was less of what we think of as conversational interface today with all of these new technologies. But it was very squarely in the utilization, effective and appropriate utilization realm. So the goal of that product was, hey, can we point someone based on level of acuity to the right care setting? And so again, can we help them, physician organization, health system, being successful in executing on their value-based strategies? It was something that right now, those solutions are far and wide, and lots of folks are moving, their suite of software to those types of answers for patients. But at the time, it was a great learning opportunity because it wasn't something that was on everyone's radar. Yeah, and it was a novel approach to it. And so we had conversations with medical directors, and they, were obviously a little bit put off by the idea, wait, somebody's going to tell my patient that, and it's not me, whether or not that they should go to the ER, and it's not a person, it's actually in technology. So that exposure to something that was maybe right tech, wrong time was a great innovation learning opportunity. It was really fascinating to understand, hey, this is absolutely a useful idea and a really needed solution. But then, there's the practical aspects of selling into a system and the sales cycle in healthcare. And so those are lessons that, being on that side of it, when we do mentorship with digital health companies that are in that startup arena, it's great to be able to tell them, here's what you can expect, especially if they are sitting at that bleeding edge and it is something that is absolutely necessary, but people are going to view it as a little bit ahead of its time, or they're just, they haven't quite wrapped their head around it. So,
yeah. Well, you serve on the board of a number of different digital health startups. Any that you may want to highlight?
Yeah, there's a couple. And I usually say yes to those types of engagements when it's something that is fairly unique and niche and obviously of great interest to me. One company that is a St. Louis startup that I've advised for quite some time is a group called Hive, HIVE, and they are a device company that's essentially remote biometric monitoring for IV lines. So things like PICC lines for hospital at home. They're kind of pivoting and looking into a new use case in central line infection monitoring because they think they have something that is novel in regards to how the technology actually works and where it sits. But if we again, it's this matrixed use case, but for utilization, keeping people that have an osteomyelitis from ending up back in the hospital because they don't do that third PICC infusion. And how do you know that? If home health is going out every once in a while. So they're just a pretty fascinating company. A group called Carelist that is going after the opportunity space of we have all of these physicians that are not just physicians. Providers have unique backgrounds and they can be superheroes, but those are skill sets that may not be known when you're looking for a physician. So, if you have a particular background that gives you more of an ability to address sexual assault, well, that may not be something that goes on your traditional find a provider website. And so this is something that is a differentiator for health systems and provider organizations that can really highlight those unique areas of skills that their clinicians can bring to the table. That is something that, given current state of affairs and the certain populations that, that might feel, I really have a hard time going to the doctor, knowing that, this is a doc that, has a community that has kind of weighed in, or they're, specifically, here is background that adds to the value of what you think of when you think of a provider in a health system is pretty fascinating. And then the last one that I'm on the board of that is really super interesting is a group called Cardio Diagnostic Holdings. Their technology, essentially, what I think of it is the hemoglobin A1C for coronary artery disease. So it's something that is both a marker of disease and then the ability to track progression or improvement over time, and in a very intuitive, straightforward way, and something that can be expanded to all large numbers of patient populations. And then let's not forget CareGauge, which is something that is close to your heart, obviously, and something that I'm advocating for inside of Mercy because it's just such a unique and focused solution to the problem of exposing our providers to utilization data. We can't address what we don't measure or allow insight into. So it's definitely something that is really, I think kind of a slam dunk.
Well, and where we're so excited about it is, the change in behavior that we see, because when doctors get utilization reports, 3 months, 6 months after the fact, it doesn't change behavior. And the fact that we're giving doctors data real time and those insights real time, we're seeing those changes in behavior. And that's what's been really cool about that product. So thank you for mentioning that.
It resonates with so many of the technology innovations that we are putting into place. It's really taking something that's obtuse and shrouded and exposing it in a way that is understandable. Super important. We start looking at predictive models and we start looking at these care recommendations that we're going to have to be very conscientious of how we build those things so that we're not removing the clinician intuition and that knowledge base, and offering up something that they can't vet. We're going to need to strike the balance between, both something that's transparent and also something that's efficient, and transformational.
Well, Damon, thank you so much for joining us today. Was hoping that we could do this one in person, but obviously weren't able to make it work from a scheduling perspective. But thank you for doing this virtually. Happy to have the folks who are able to join us today live join us. And of course, we'll be posting this recording online and on the EvidenceCare website. And so, Damon, thank you so much again. And great seeing you.
Pleasure speaking with you, Brian. Have a great day.
Thanks. You too.